Thank you, Professor Walton, for that lecture, but he's, of course, offline, so we won't be able to ask any questions. Next, it is my great pleasure to invite Professor Asfar Zaman, the Professor of Cardiology at Newcastle, and the Cath Lab Director and the Interventional Head of Freeman Hospital, somebody that we always looked up to when I was training as an Interventional Fellow in Wales and in Edinburgh, and as a young consultant, looking at your papers, to see how we could do TAVI and make the situation better. He's a Fulbright scholar and has also had the BHF Fellowship in Vascular Biology and a number of peer-reviewed publications. So we are indeed delighted to have you, Professor Zaman, and welcome to Sri Lanka College of Cardiology sessions.
Great, thank you for the invitation. It's a real pleasure to join you all here today. So my talk is on managing complications of TAVI. As you've heard today, TAVI has now been around for 20 years, and so there's a real wealth of data now about how best to deliver this procedure, but also a wealth of data about complications. So the good news is that if we look at the evolution of TAVI, and you look at the top here, which is about incidence of mortality, you can see that it has come down as valve techniques have improved and as the valves themselves have improved. And the second graph just below is about stroke rates, which is one of the things, of course, that we worry about most because these are elderly patients. The mean age of patients undergoing TAVI at our centre is 84. And the last thing they want is to have a working aortic valve, but to be left with a stroke. So the incidence of stroke has also declined, but we have a long way to go, and there's lots of data, research currently going on, particularly in the UK, with the TAVI Protect trial looking at deflector devices to see if we can reduce the stroke rate. If you look at the bar chart on the right, you can see that the complication rate, and this is for Asia data, so I now want to move away from European and American data where the TAVI implantation has been around for quite a while, and you looked at the bar graph to the right, and you can see that causes of 30-day mortality is that the single greatest cause is still a cardiac cause, i.e. some complication during the procedure. Vascular complications now in Europe and America down to less than 3%. Here the data from 2021 shows that the major vascular complication is still just over 7%. One of the recurring themes, and you'll see this from other data, has been that of renal failure. And these are reported by the Japanese and Asia-Pacific group, where it is now the single biggest cause of complications after TAVI in the latest data. And this tells you about the incidence of complications across all the registries that have been published to date. And this was published in Asia Intervention. And if you look at the bar chart to the left, which is an Asian study, and just to the right of that is the current Asia Pacific study, and to the extreme right is the Japanese ocean study. And you've got light blue, which is mortality rate, dark orange stroke, grey is bleeding, yellow is major vascular complications, and the blue is acute kidney injury. Acute kidney injury is something that we haven't placed great heed to previously, but the current registries are now telling us that if you look at the blue here, across the registries now, that acute kidney injury is a cause of major complications after TAVI. Now, these are patients who are elderly, but it's not just because of the contrast used for CT. It is thought to be also embolic phenomenon when we deploy the valve or we do balloon aortic valvuloplasty prior to deploying the valve. If you look at the mortality rate, that has in the modern era now is well below or just close to 2%. So that has been a real achievement in TAVI moving forward. I can't talk to you about all of those complications, but what I thought I would do is mention to you the major complications, and I'm going to talk about 4 major complications and the consequences of these, and then show you real examples of how we deal with them. So embolization and malpositioning, acronym TVEM, are a major cause of complications. Okay, thankfully they are reduced, but when they happen, they cause major outcomes, death and or going to cardiopulmonary bypass surgery. You have to be aware of what causes embolization and malpositioning. And the single most important cause is a high deployment or an undersized prosthesis. And I cannot emphasize, I will come back to you again, that the role of sizing your valve, the role of CT assessment is as important as performing the procedure itself. I will show you cases, but if you get embolization, then snaring with a balloon and anchoring in the descending aorta is the way forward. If you have high deployment, then you get a pop-up, and that will cause embolization. You can also get embolization into the left ventricle, and that is typically caused by a low deployment or a failure of rapid pacing. If you have low deployment and part of your valve is in the left ventricle outflow tract, you can then put a second valve in, a valve-in-valve implantation, or you can try and snare it and pull it up. If the valve has embolized into the left ventricle, then of course the solution is cardiopulmonary bypass and surgery. Okay, I'm going to show you some real live cases in our center of high deployment. So this was an embolic movement of the valve, which caused, as you can see on the right here, coronary occlusion. Okay? So the valve was deployed, as you can see on the left, and then it moved up, it embolized, which you can't see here, and as you can see with the pigtail, there was ST elevation, so we took a pigtail, and you can see there is no coronary flow at all. So what did we do? There was, you can see the end snare here. We snared the valve. We moved it up. You can see here on the right, and you can see coronary flow again, and there was gradual reduction of ST elevation. The patient had crashed. There was CPR ongoing. As soon as we snared the valve, the coronary flow was restored, and the patient survived. So what did we go on and do? So the next thing was that we deployed a balloon expandable valve under rapid pacing, and you can see the final result here. We left the embolized valve in. You try and bring it as far back as you can, avoiding the arch where the carotid, the subclavian arteries are, and you leave it there. Okay, you leave it there and you place a second valve. The second valve can be the same valve, but in this case, because we have more experience at our center with a balloon expandable valve, we chose to use a balloon expandable valve. It's not just with a self-expanding valve. Okay? With the self-expanding valve, there have been a greater incidence of pop-ups, as we call them, but we can also have it with balloon expandable valves. And I'm going to take you through this case in our center once again with a balloon expandable valve. So you can see this. There is a safari wire in the left ventricle. There is the valve that is across the native valve. There is a pacing wire, and we deploy this under rapid pacing. And if you see this happening, what happens, we believe, is that at some point the pacing doesn't capture, there's an ectopic beat, and the valve is embolized. We then use the balloon of the valve to drag this embolized valve round to the arch, and ideally you want to bring it round into the descending aorta. I'll show you what we should do, and then we place a second balloon expandable valve, and this time there is no ectopic beats, the pacing works perfectly, and the valve is deployed, as you can see here. And you have this second valve here. You can see the balloon, and we try and bring it with the balloon round into the descending aorta. With the balloon expandable valve, you can use the balloon to bring it back. With the self-expanding valve, typically you have to snare it with the end snare device to bring it back into the aorta. Ideally, this is what you want. You want to bring the embolized valve into the descending aorta, and because the valve then turns as you bring it into the descending aorta, there is no problem with loss of flow into the descending aorta. And you can see this with a TOE, and the valve has been brought into the descending aorta, and the patient does well, there is no problems, and if you can achieve this result, it is the best outcome. So, how do you manage aortic embolization? The key thing, of course, is never to lose your guide wire position. Provided the guide wire is through the aortic valve, you are able to snare, you are able to use a balloon to bring it round, but the key thing is that the valve must not flip round. If the valve flips, you will have loss of flow, and it becomes a critical condition that requires surgery if the patient can survive. You have to assess hemodynamic stability. You have to pull the embolized valve, the transcatheter valve, across the arch as far as possible into the descending aorta and deploy it there. Typically, because the descending aorta is larger than the ascending aorta, you may need to post-dilate with a larger balloon. And you need to secure that transcatheter valve in the aorta. It is not without consequences. Both aortic valve embolization and ventricular valve embolization. So if you look in the blue, it's what happens if the aortic valve embolization occurs, i.e. the valve goes into the ascending aorta. If you look at the mortality, 30-day mortality, it is high. It's 17.5%. So valve embolization is not without its consequence. Even when you succeed in deploying it further down into the descending aorta, the 1-year mortality is over 30%. It is significant. What happens if the valve is embolized into the ventricle? And you see this in the red here. That has an even higher 30-day mortality. In this study, observational registry, it was 26.8% mortality, and the 1-year mortality was 38.5%. And of course, one of the reasons why it has a higher mortality is because if the valve embolizes into the left ventricle, then the only treatment for that is cardiopulmonary bypass and surgical correction. So both left ventricular transcatheter valve embolization and aortic transcatheter valve embolization are associated with significant mortality. The ability to treat these successfully is important. Okay, but even when we treat them successfully, remember, they still have a significant associated mortality. So in summary, periprocedural TAVI valve embolization occurs not in too many. In this registry of over 29,000 patients, it's just under 1%. Of these, 217 were to the ascending aorta and 56 to the left ventricle. So it's quite clear that when you have these, typically they are pop-ups into the ascending aorta. Self-expanding or the first generation prostheses are more likely to happen, and of course you need to be wary in bicuspid aortic valves, because we know that in the bicuspid valve, because of the shape, the valves are more likely to embolize. If this happens, you need to have a second, typically in 83% of cases, or just under 20%, 90% convert to surgery. So when you see this in the left ventricle, if you see the pop-up, if the patient is able to go into surgery, don't be afraid of taking the patient to cardiopulmonary bypass, and they should be consented accordingly pre-procedure. That case that I showed you, the patient died 2 weeks later from a stroke. So even though you can survive the initial procedure, the major risk of stroke is significantly greater. It's about 4-fold greater at 30 days. But if they survive the 30 days, then that stroke rate mitigates out to 1 year. So what is the second significant major complication that you can get during TAVI? So I'm going to show you a case of annular rupture, and at the time it is near fatal. Okay, we've had 3 of these, 2 have been fatal, 1 survived after going to surgery. It does lead to immediate hemodynamic compromise, and the management, there is nothing percutaneous that we can do in the management. The patient does need to go to cardiopulmonary bypass if he or she survives this initial procedure. So this was a case of deploying a 26 millimeter Edwards Sapien valve. Absolutely no problems at the time, but then after deployment we get annular rupture and the patient destabilized. The other problem is aortic dissection. So you can get aortic dissection of the aorta, and these are 2 cases. One is with a balloon expandable valve. You can see just here a dissection of the aorta that I'm pointing out. You can't see here. So just here, if you look at that line here, there is a dissection flap that is seen after deployment. Oh, you can see it here, just here, okay? And then on the right, you will see, can we play the image on the right, please? This is with a self-expanding valve. Sorry, if you play the image on the right.
Can you please try to play the second image, please?
That's great, thank you. So this is a self-expanding valve, and you can see that we use the pigtail to try and see where the position is. Let it play on a loop. And you can see that with the pigtail injection, here you can see the dissection flap. So you need to be aware and wary that with both sets of valves, aortic dissection is possible. Okay, I'll just let this play so you can see. So on the left, you see the dissection just above the valve, and on the right, just at the tip of the pigtail. So how did we manage this? In the first case, with the balloon expandable valve, the hemodynamics of the patient were unchanged. We did an on-table echocardiogram. There was no pericardial effusion, so this patient was managed medically. We repeated the echo on day 2. We then repeated a CT scan on the 3rd day post-TAVI, and there was no pericardial effusion, and this lady was allowed home, and she is doing well. The second case with the self-expanding valve, and we believe that that dissection was caused by the pigtail, there was immediate hemodynamic compromise. The on-table echocardiogram showed a large pericardial infusion. Although the drain was inserted, there was free drainage of blood. The surgeons were informed, they came into the cath lab, but en route to theatre, the patient expired. So aortic dissection, by nature type A, can be fatal, but the key thing is pericardial effusion. Look at an echocardiogram. If there is no pericardial effusion, you can manage the patient expectantly, conservatively, but you have to repeat the echo to look for pericardial effusion. The pericardial effusion is a marker of poor outcomes. So, how can it occur? Of course, with wire and catheter manipulation. I keep telling you earlier about making sure the size of the valve is appropriate, how important the role of the CT and the person who analyzes the CT is. If you oversize the valve or balloon, you risk a type A aortic dissection. How you move the balloon. You need to be gentle with the balloon. You need to be gentle with the valve. And of course, in the second case that I showed you, The pigtail injection, so we were giving 20 mils at 10 mils a second when that dissection occurred. We have now, in terms of just seeing how to position the valve, we have moved the pigtail injection to 5 mils per second injection. Remember, the pigtail is trapped behind the self-expanding valve, and any pressure that the more pressure that you inject in the valve, if it's trapped and the holes are pointing to the wall of the aorta, you are likely to cause a dissection, as happened in that second case. If you see a porcelain aorta, these patients can't go for surgery, but remember, a porcelain aorta is fragile. Be careful with your injection, be careful with your sizing. If you have a narrowed calcified sinotubular junction, you are more likely to get type A aortic dissection. The key to reducing the risk of complications, both of embolization of type A dissection, is accurate valve sizing. Case planning with CT imaging is absolutely critical. You have to assess the annular complex size. You have to assess the location of the calcium. Is it present in the left ventricular outflow tract? You are likely to cause annular rupture. If you have a lot of calcium, it may make sense to use a self-expanding valve rather than a balloon expandable valve. So the appropriate size is absolutely critical. One of the things that we need to understand is that the annulus itself is a dynamic structure. It changes in systole and in diastole. If you are aware that it changes during the cardiac cycle, you need to know that the largest size is during systole when the valve leaflets are open. In diastole, the size is smaller. So it's important that you make these measurements during systole, because if you make it during diastole and you get a smaller valve size, the risk of pop-up either into the aorta or into the ventricle is increased. If you oversize, the risk of rupture or type A dissection is increased. So sizing is critical. It's important that the individual or individuals who analyze your echoes are skilled at doing so. The third major occlusion, which often can be fatal, is coronary occlusion. You've heard the previous speaker talk about this. You saw our case of this. When this happens, you have a crisis. You see immediate hemodynamic collapse. You see immediate ST elevation. And it usually results from the calcified valve leaflet rising as you deploy the transcatheter valve and obstructing the ostium. And you can see this on the right where the calcified valve has obstructed, this is a post-mortem specimen, has obstructed the ostium. You need to be aware because you can predict this before the procedure. Valve to coronary height, as you heard before. Small sinuses that don't allow the valve to be to go into the sinus, is more likely to lead to valve occlusion. You can do this also, predict this on the CT. So in this case, the left main ostium was 16 millimeters from the aortic valve plane. But also, there was a large calcified valve, which also was 16 millimeters. So you can imagine that as the valve is deployed, that leaflet, the native leaflet, will rise and obstruct the ostium if the sinus is not large enough to accommodate it. So how can you prevent it? Okay, so if you can see here, in this case, we have a catheter and a wire, a guide wire, inside the coronary artery and a balloon and a stent inside the left main. So if you think that the chances of coronary occlusion are high, you can take preparatory action. And that is that you have a guiding catheter, you've engaged the coronary, ideally into the left anterior descending artery, and you have a stent inside the left main stem. as the balloon is inflated, or indeed with a self-expanding valve, you then inject in the pigtail. If you see that the coronary is dilated, you have the stent inside the left main, just outside the left main, and you deploy the stent as if you think that the left coronary is obstructed. So there are ways of mitigating this by maintaining access to the coronary valve during your procedure. The fourth complication, and we are only seeing this as we maintain and collect data in our patients. And this is, we are saying, in the Asia-Pacific region, that the incidence of acute kidney injury is greater than what we record in Europe or in the States. So how can you mitigate this? How can you try and prevent this? Well, pre-procedural. You can do these procedures without a CT if needs be. You can size the valve using a transesophageal echocardiogram. If you do a CT, then wait 7 to 10 days before you do the valve procedure. You can assess the peripheral vasculature using minimal contrast during angiography. You can oral hydrate or use IV hydration of the patient prior to the TAVI procedure. We have now done multiple cases of single access TAVIs. So this is with the balloon expandable valve. If there is a large amount of calcium on the valve, it's visible on angiography. We just use a single access to deploy the valve. We have done cases with no contrast whatsoever if valve calcification is visible, and this is easier done with the balloon expandable valve. There have been trials of forced diuresis and matched hydration, but in the TAVI population, this has been associated with an increased mortality at 1 year. So the advice is not to do forced diuresis in your TAVI patients. Lastly, vascular complications, and I'm going to keep this brief because as the French sizes of the TAVI devices has reduced from when we started at 24 French to now 14 and 16 French, the vascular complications has reduced accordingly. But successful management relies on the operator and the team being prepared for when it occurs. You need to have the necessary equipment in the room. Occlusion balloons, covered stents. You need to have the expertise available. You need to have vascular surgery available quickly if needed. The first priority is to control the bleeding through endovascular techniques, typically with occlusion balloons, perfusion balloons. And in this elderly population, we have put covered stents into the common femoral artery without any sequelae. So you must have the right equipment, you must be prepared, the team must be prepared. Typically, repair can be performed surgically, or we have the interventional radiologists who will come down and bail us out. But when we first started in Europe, the vascular complication rate was around 5 to 7%. As I said, these were with 24 French devices. We're now down to below 2% with our 14 and 16 French devices. So in summary, ladies and gentlemen, over 20 years of evolution of the transcatheter aortic valve implantation, we have seen a huge improvement in outcomes in patients with severe aortic stenosis. The previous speaker showed you the improvement in outcomes and the reduction in complications. Whilst complications are rare, because these are largely elderly population, the complications can have fatal consequences, either mortality or stroke. So it's important that we try and minimize these. Unfortunately, we are able to do this, but the key thing is planning. Accurate assessment, skilled assessment of the CT, sizing of the valve, a pre-procedural echocardiogram, assessment of the patient's comorbidities, and being prepared for the complication, having all the tools to hand inside the cardiac catheter room where you're doing the procedure, can and will improve outcomes if they occur. The one thing that we've talked about and we're slowly trying to implement is because these complications are sudden and they're serious and they can be fatal, is that for some cases where we predict on CTs, we have 2 consultant operators for approximately 15% of all our procedures. Thank you for your attention.
Thank you, Dr. Saman. So that was absolutely wonderful, in terms of having an overview about all the possible complications that you should know before you start a TAVI program. I just wanted to ask you a few questions, if you don't mind, about your use of embolic protection devices, in terms of elderly population who you think might have a higher risk of a stroke. What percentage of patients do you use a Sentinel device or, something equivalent to that?
Yeah, so clinically, it was 0, but we're doing the BHF Protect trial at the moment, so we're randomizing patients to embolic protection or standard therapy. So at this moment in time, because of this trial, around 40% of patients are getting an embolic protection device. This is a 3-year study to look at the end to see whether we make a difference in strokes. If you ask for my opinion, if you look at when the strokes are occurring, they're not periprocedural. They're often after the procedure. So how much these embolic protection devices will lead to a reduction in stroke, I'm not so sure. There's good data to looking at MR scans of the brain to show that you get less embolic phenomenon inside the brain, but in terms of stroke reduction, there is not good data as we have at the moment. One of the other things that we see, and something that we're looking at, is that often in many patients after a successful TAVI, you see an increase in blood pressure. And is it this that is leading to a stroke rate a week or a month later? I don't know, but we're looking to do a trial to see if we can bring down the blood pressure to baseline post-procedure with medication and see whether this has an impact on stroke. So I think the mechanism of the stroke needs better clarification before we can find devices or treatments to reduce it.
It's actually nice talk. I just want to ask about now. I think this, I have also seen this trial because when I was there last year, you are doing this embolic protection device. Only thing is it takes time, right? So the procedural time increases, placement of, these things. Now, what about the pacemaker, the increased risk of complete heart block, which I have seen sometimes more commoner than, other complications.
Yeah.
So in that case, what is your,
So the reason I didn't mention the pacemaker is because that's clear, okay? You see it mostly at the time, you will see some a bundle branch block or typically some rhythm disturbance. So you then keep these patients for 48 hours, monitor them. Now, we've seen that around 62% of our patients, if they get conduction blocked at the time of the procedure, after 2 days, it resolves. Okay? So the pacemaker rate for the self-expanding valve in our center is around 18%. For the balloon expandable valve, it's about 5.4%. I have no problems with the pacemaker rate because these are elderly patients, and my view is that at some point they would need a pacemaker anyway. Okay? So all you've done is bring it forward. So I don't see that as a complication. This is why I didn't mention it in this talk. I almost see this as the price to pay for giving these patients a better quality of life. And I think if they didn't have the pacemaker at the time of procedure, they will require it in 1 to 2 years' time. Yeah.
Another good thing actually I learned from you is this zero contrast procedure.
Yeah.
Right? And I have seen you are deploying the valve without any contrast. Right? As opposed to fellows are always requiring the contrast to come in.
Yes. So this is for the, just to make clear, it's for the balloon expandable stent, where you have, where you can see the calcium very clearly on the valve, and you can then place the balloon expandable valve without contrast. Yeah.
Dr. Saman, that's lovely. Thank you very much. And then in the interest of the other speakers who are waiting online at the moment, I think we have to wind up. But I'm sure you can direct your questions to Professor Saman as required. Thank you very much.
Thank you, Professor Zaman, and I'd like to thank all our chairpersons. So without much ado, we'll proceed because we are all very lucky to hear a great CTO interventionist, Dr. Wataru Nagamatsu, who is waiting for us to come on live, and he'll be talking about approach to CTO interventions. I would like to invite the following consultant cardiologists to chair this session. I'd like to invite Dr. Jayanthimala Jayawardena, Dr. Roshan Paranamana, Dr. Rahuman, and Dr. Amila Valawat. Thank you.
Good morning. We are moving to the next sessions. That is how to approach CTO interventions. So today here we have eminent cardiologist. He's an interventional cardiologist from Japan, Dr. Wataru Nagamotsu. He's an interventionalist attached to Hokusetse General Hospital, Osaka, Japan. He's the course director of CTO Club Japan and CCT Kobe. He has performed live demonstrations and CTO workshops over 250 in foreign hospitals. I think he is online now. Dr. Nagamotsu, please start your lecture.
Okay, and good morning. And first of all, I'd like to say that I deeply appreciate inviting me. Thank you very much. Okay, I'd like to sharing my slide. Can you see my slide? Can you see my slide? And can you hear my voice?
Yeah, we can hear you and we can see your slides now.
Okay, thank you very much. And so this session they have the 30 minutes around. I would like I would like to do this lecture that 25 minutes around. Thank you very much. So my lecture title is Approach to CTO or Interventions and How to Build a Strategy and using the actual case. My conflict like this. The case is I would like to show the one case for this lecture. The case is a very young gentleman, and he suffered from a stable angina. There are some of the risk factors. The EF is good, and the renal function is so-so. And he already received the previous PCI and the circumflex. And unfortunately, he didn't have the heart CT exam. So I would like to show that this actual CAZ. So this case I performed, and for the live demonstration, the aim of this live demonstration is open the LAD. Open LED means there, LED CTO. Okay, this direction is our cranial view, and as you can see, we can see the CTO part from the middle part of LED. And the branch is the big septal branch, and this part is a total occluded part. And continuously, this occluded part continuously and leads to the around here. And but unfortunately, CTO distal part and the quality is not so good. And simultaneously, and we can see there are collateral channels. This proximal part of the collateral channel that seems like connected to the posterolateral branch. And we can see the another very fine collateral channels that connected to the diagonal. So this one is another view. This one is an iliocranial view. And as you can see, we can see the big and circumflex branch. So maybe the anatomy is left dominant. And we can see the total occluded part and of the circumflex is here. And at the branch, this big posterolateral branch, here is the total occluded part, portion part of the circumflex. And continuously, this total occluded part is connected to here. But unfortunately, this circumflex CTO and this part is not good quality. And this one is spider view. And as you can see, left main trunk is okay. And the previous PCI part is the portion part of the circumflex is clear. This one is our color view. And as you can see, we can see there are some fine septal channels. this septal is connected to the circumflex CTO, and maybe the distal part of the circumflex and connected to the distal part of the LAD, like that. This one is RCA angiogram. So actually, this RCA is a small one. So, and we have to open the LAD CTO and the circumflex CTO. Okay, we have to discuss our indication, but this patient strongly want to receive the PCI. I should see the summary. And so this anatomy is the LC dominant, and the mid part of the LAD total occluded. And this circumflex is the total occluded, and proximal RCA and the CTO total occluded too. But this one is a very small one, and we can care about the optimal American therapy. And I will show you again the LAD CTO summary. The entry is ambiguous and just branches the big septal. The length is a 20 millimeter round, and the proximal part we can see the clarification. And the tortuosity, we don't know. Very unfortunately, we don't have the CT angiogram. The distal part is your, this picture is a magnified one, and poor quality. It seems like very difficult to insertion the guide wire from the antegrade. And the collateral channel is ipsilateral septal and the PL to the diagonal. But how about the difficulty of this LAD CTO? And we can have the good tool and the JC2 score. And from the JC2 score is there ambiguous and the clarification. So the total score is the 2. 2 means the difficult. So actually the this paper, the purpose is how about the guide wire cross within the 30 minutes. So, and so this difficult category is within the 30 minutes, and the guide wire passage rate is less than 50%. So which procedure is better for LAD CTO? We have so many options, and one is antegrade, and the opposite side we have the option the retrograde side. And for the antegrade side, I was guided entry for the ambiguous entry and the double movement capacitor for the getting a good back support and the power wire. So we have many options, but which one is better? Which one is mean the antegrade or the retrograde? Usually, Buddha asks this issue. So my procedure, the key point of this LAD CTO is poor quality. So I already mentioned about this poor quality. Due to this poor quality, very difficult to insertion the guide wire from the antegrade. So we have the good algorithm. So this one is one of good algorithms. My favorite one is APCTO. APCTO Club is a perfect CTO Club and algorithm. And they're already published the Jack. And this the first author is my friend Scott Harling from New Zealand. So anyway, and we can see that this line, this part is the proximal cap ambiguity. So this issue much adds this case, and the ambiguity is yes, and okay, that we can do the I was guided into the yes. The poor quality distal vessel or the deviation at distal cap. So unfortunately, this LAD CTO have the poor quality distal vessel. So we have to consider about the intervention quarter present. So from the by this APCTO Club algorithm, we have to consider about retrograde PCI procedure. So this case have the intervention quarter present or not. Nowadays we have the good algorithm. Another good algorithm is a global CTO crossing algorithm. So this one is actual and global one. So and from there, Asia Pacific and Europe and the US and China, and so the main organizer and the talk discussed about this global CTO crossing algorithm. So this paper they're already published from the Jack. Anyway, so there from this global CTO crossing algorithm suggests and the same opinion. So the poor their basic quality, and when this CTO have the poor this basic quality, we have to consider about the letter grade option. How about this case? So this RL corridor view, we can see the quarter channel from the circumference to the LAD. Can you see? Very fine one. Seems like a thread like, but we can see. And I would like to show this schema. So the first M is the LCTO here. And additionally, we can see that this circumference here. So this channel is the distal part of the CTO and distal part of the circumference CTO connected to the LCTO distal part via septal. So I wonder, so if this channel is interventional, once open the circumference CTO, and after that, using this septal channel, we can perform the LCTO with lateral grade. How about this channel is intervention or not? So there usually bother us this issue too, but we developed this J channel score. So this J channel score already published your intervention. And please look at this one. So the total the score is 2. 2 means please use this vertical line that defines the septal and the small size, but there's no bending. So the total score is 2. 2 is the intermediate. From the Japanese CTO expert registry data, that if this channel be in the intermediate category, guide wire crossing success rate is excess 50%. Excess of 50% is maybe this channel is an interventional one. We can try to this one. Circumflex CTO PCI is a better way for preparation of LAD CTO PCI. Okay, and I would like to recheck the circumflex CTO. This circumflex CTO is poor quality too. And please remember the previous picture. Very unfortunately, this part of this circumflex CTO is diameter small and included some the plugs. So the CTO score is only 1. The issue is just only the length, and the intermediate one. And the intermediate within 30 minutes, guide wire crossing the ratio is excess 60%. But from the APC to crown algorithm, and if this CTO have the poor quality distal vessel, we have to consider the lateral grade. How about this channel? This channel means the proximal part of the septal connected to the circumflex. This one is an intervention channel or not. We can check using this J channel score again. And this channel is actually the septal one. And we can see that the channel size is like a branch, not straight right. So the large, there is no the reverse band and the condense bands and not corkscrew. So seems like this channel is complicated. But from this J channel score, it's just only the total score is 0. 0 is be in the easy category. And from the Japanese CTO expert registry data, the guide wire crossing ratio is excess 19%. So this channel may be the interventional one. And another point of view, and the point of view is focus on the time. So this one is another good algorithm, a novel algorithm for treating the coronary current total occlusion. So this algorithm is conducted from the Japanese CTO PCI expert registry, and this paper is already published via JACC. So please look at this one. The guide wire crossing manipulation, and the time is and after that, 20 minutes passed. We have to consider about the continuous and more intentional antegrade or the switching the lateral grade. And please look at this part. In the consideration of the lateral grade approach, intervention required at least one variable. The attempt CTO length and excess the 20 millimeter and CTO entry type no stamp. For this case, and we have to consider about the retrograde. And this paper showed another good information. We look at this. Rescue retrograde approach. Rescue retrograde means fail the antegrade and switch to the retrograde, mean the rescue retrograde. And primary retrograde. And approach were 126 minutes and 107 minutes. If we try to the retrograde, and we have to do the primary one for the saving of time. And look back to my data, my CTO data 2016. So guide wire crossing time and at wire success cases. The primary retrograde one is the median is 110. The rescue one is 180. If we perform the retrograde, the primary is better than the rescue. So, and I performed there for this case is for the circumflex CTO, I performed the primary retrograde. So, and I used a 7 French system, and I used Asahi and Carabello 150 centimeter microcatheter. I performed the tip injection. Looks like nice. The diameter is good. There is no severe bend. Maybe we can pass through this channel. I choose the SUO03 guide wire. 03 is, as you know, and very quite a soft one. As you know, conventional guide wire, workhorse guide wire, the tip load is 0.5 to 0.7, like I see on the symbol, but this one is 0.3 gram, very soft one. So very suitable for the channel negotiation, like the previous channel. So anyway, the pass through using a SUO03 and the Carabello microcatheter, pass through the CTO distal part. And after that, and I try to the reverse cut technique. And so actually this retrograde channel is the ipsilateral one. So I perform the pinpoint technique using the 7 French Hyperion SPV 3.5. And actually this CTO region is very quite hard. And I set up the Sasuke dual, Asahi Sasuke dual microcatheter. And I performed the reverse cut technique using the 2.5 millimeter balloon and UV3 and success like that. And the retrograde guide wire pass through to the antegrade system. And I performed external Z and external Z. And I implanted 2 stents like that. I success this circumflex CTO. And after that, and open the circumflex CTO, and we can see more clearly that this channel means from the circumflex to the LAD. Can you see? And that's all. This channel score is here 1. 2 is there intermediate one is there have the possibility pass through the guide wire. And I perform a tip injection and using carbon microcatheter, and more clearly see due to the isolation and more accumulation by the contrast. So, and I used again the SUO03 guide wire from the circumflex to the LAD, like that. So this SUO03 guide wire have a very good performance, very easy way to pass through the distal part of the LAD CTO. And I checked the IVUS, and for their IVUS guided entry, and because of this LAD CTO entry is ambiguous. So I inserted the guide wire to the septal branch, and additionally, I inserted the IVUS. And as you can see, from the 9 to the 12 o'clock, we can see the LAD. And I performed to stick to the CTO region and using the Asahi Sasuke dual lumen microcatheter. Firstly, I chose the intermediate guide wire UV3, but failed. I escalated the guide wires, Miracle 12, and the guide second, but failed. It seems, as you can see from this picture, this guide second seems like very easy to weigh the perforation and from the beginning of the CTO. So we have to change my mind, like previous Japanese CTO expert legislator algorithm. Okay, and we have the good the paper. So this paper is an overview with the three subtypes of the reverse cart. One is a conventional one, and a directed one is extended. So extended means that we don't need insertion from the antegrade. We can perform the in front of the CTO. So, and how about this? And as you can see, we can see the plug in front of the CTO. Maybe we can perform extended reverse cart and making the intentionally the cracking created the extra plug dissection and insertion of guide wire, and for the retrograde, maybe we can do that. So, and the preparation for the extended reverse cart, I tried to insertion the guide wire from the retrograde and using the UV3. So in this time, I have fortune. So this UV3 pass through the antegrade system, and guide wire pass through from the retrograde directly. And there, additionally, the Caravel microcatheter and the Corsair microcatheter pass through this CT root, and I perform externalization and the guide wire insertion to the using a dual lumen microcatheter Sasuke. And after that, I open by balloon and I implant the stents 1 and 2, and I show the final angina. So there, and as you can see, and the circumflex and LED CTO and open. This one is the cranial view. There's no the complication like that. There's no complication at the channels too. I will show the procedure summary. The procedure time is 238 minutes, but actually this one is a live case demonstration. And I discuss about 30 minutes, at least 30 minutes. Maybe there are about three hours and a half. And the dosage of the contrast medium is 240, and because I perform the retrograde PCA procedure, so due to the performing the retrograde PCA procedure, we reduced using the contrast dose. And fluoroscopy time is 90 minutes, very reasonable. But this patient, the body weight and the machine, and the machine status, and very unfortunately, the radiation exposure is big. But there's no complication after that. Take-home message: the approach to CTO interventions, how to build a strategy. The scoring and algorithms will be beneficial for the building our CTO business strategy, like this actual case. And although scoring and algorithms have limitations, and they are useful for information sharing and standardization and education. Thank you for your attention.
Thank you, Dr. Nagamatsu, for that excellent lecture in how to approach a CTO. We have little time for a question or two. In the absence of questions, we would like to thank Dr. Nagamatsu for that excellent lecture in the traditional way.
I'd like to thank our chairpersons, and we are proceeding to the next symposium. We are actually not going to do the peripheral interventions because we have an issue, and our speaker will be coming on later on after lunch. So we are going to proceed with structural heart disease. And I would like to invite the following consultant cardiologist to chair this session: Dr. W. Shantaraj, Dr. Vasanta Kapuata, Dr. Shehan Pereira, and Dr. Chintaka Hatlawat. Thank you.
Good morning, ladies and gentlemen. Good morning, Dr. Sivakumar. This is Shehan. Can you hear me, sir?
Good morning, Shehan. Good morning, Shehan. Am I audible?
Yes, you're audible, sir. So the next symposium is on structural heart disease, and Dr. K. Sivakumar does not need any special introduction. He's a very renowned pediatric cardiologist who works as the chief pediatric interventional cardiologist at Madras Medical Mission in Chennai. He has worked in Sri Lanka, and many of us, including the pediatric as well as the adult cardiologists, know him. He's a very humble and nice person, a very good teacher. Dr. Sivakumar has published many articles in all renowned journals, and is a frequent speaker at many international conferences. Also, as many of you will know, he's a frequent operator at many live demonstrations which are aired all over the world, and especially at CSI Frankfurt. So I won't take too much time. Over to you, sir, to tell us about the technical aspects of PFO closure as well as coarctation stenting.
Thank you very much, Dr. Shehan. It's a pleasure to interact with all of you in the Sri Lankan College of Cardiology. I distinctly remember the year 2006 when Professor Valupillai, Dr. Thinabadu, Professor S.R.D. Silva, and Professor Ruvanikanaike were heading the institution. And it was such a nice, long friendship that I share with all of you. I heard that Dr. Shantaraj is also on the podium, and my very humble respects to Professor Shantaraj, who is one of the very senior person. And without much delay, I will discuss the two diverse topics. One is on coarctation and one is on patent foramen ovale. Now, let's talk about what are the indications for coarctations of aorta for a transcatheter management. We feel if coarctation accounts for around 6 to 8% of all congenital heart disease, and why should we intervene in a coarctation? Coarctation has got only a 50% survival up to, if you have a natural history up to 32 years, and if you follow them up to 60 years, almost 92% of them will be dead, and the death will be in a neonate with heart failure or an adult with atherosclerosis, dissection, rupture, hypertensive heart failure, pulmonary edema, sometimes flash pulmonary edema, pregnancy-related complications, cerebrovascular accidents, brain hemorrhage from berieaneurysm. It's broadly divided into simple coarctations and complex coarctations. What many of the neonatologists and infantile pediatric cardiologists say will be complex coarctations, those associated with VSD, AV canal defect, or cyanotic heart disease, or Sean variants. Very often they will need immediate surgical attention. And what we in the usual adult or older age practice will see is simple coarctations, those who are either isolated coarctation or those associated with patent ductus arteriosus. The conventional indication for correction of a coarctation is a clinical blood pressure difference of 20 millimeters of mercury between upper and lower limbs. And we need to be aware that sometimes the left upper limb may be lower in pressure, either because the left subclavian artery is arising from the region of coarctation, or the left subclavian artery itself is stenosed, or it may be a pre-subclavian coarctation. And we also need to be aware, sometimes the right subclavian also may be lower in pressure if there is an aberrant subclavian artery that is arising distal. But in general, clinical blood pressure difference of 20 millimeters of mercury, or if you are having a patient who is on exercise demonstrating a 50 millimeters of mercury gradient, they become indications. A typical hemodynamic trace of a coarctation is shown here, where the upper limb will have very wide pulse pressure that makes the pulse very easily detectable. The lower limb will have a very low pulse pressure, and so that makes the pulse weaker. Remember, the pressure is not low in the lower limb. The pressure is normal. The mean blood pressure in the lower limb is normal, unless the patient is in shock. But what is seen is a low pulse pressure that is felt as a feeble pulse. It's the pulse volume which is low, but not the mean pressure which is low. Whenever we have a weak left arm pulse, we need to be aware that it may be due to left subclavian artery stenosis, or the coarctation is pre-subclavian, or sometimes if the patient is post-left subclavian flap aortoplasty. Most often, what we follow is an echocardiographic gradient, and what we like to see is a signal that spills on into diastole, having a mean pressure of more than 20 millimeters of mercury. But we need to be aware that there can be a low gradient coarctation, just like a low gradient aortic stenosis, if the patient is having extensive collaterals. This is one of the reasons why I say exercise-induced gradient of more than 50. Sometimes if we have too many collaterals, the coarctation may not have a gradient, but the patient starts walking, he will have a gradient of 20, and the patient starts walking a little bit fast, he'll have a gradient of 40 to 50. And when he runs, the gradient goes to 60 to 70, and he goes into hypertensive heart failure and flash pulmonary edema. If there is a severe aortic regurgitation, or in a small baby with very severe pulmonary hypertension with low cardiac output state, LV dysfunction, a neonate with shock, a large PDA, sometimes in univentricular heart, even a low gradient coarctation is a significant coarctation. I was talking about collaterals. If there is very, very, very extensive collateral, sometimes your gradient may be masked in the resting state when you are keeping the patient in a lying posture and you are recording the blood pressure. We also need to aware that this is basically the advantage of doing a coarctation transcatheter intervention instead of surgery. Imagine the plight of the surgeon who has to deal with this leash of collaterals around the aortic arch, and when he tries to go and dissect on the proximal and distal end, he'll be injuring many of the intercostal collaterals, and hence transcatheter strategy is now considered to be a preferred strategy for majority of the patients with coarctation. Collaterals may vary from patient to patient. It is very difficult to identify which patient will be a safer subset for a surgery. And so in general, if a patient is suitable for a transcatheter intervention, that is preferred. The first major challenge in a coarctation is very often missed. May have very subtle findings, especially in an adult. The echocardiographic windows in the distal arch may not be sufficient enough. You may have a low velocity abdominal aortic Doppler. You may have unexplained mild to moderate mitral regurgitation. You may have mild to moderate left ventricular dilatation or left ventricular hypertrophy or left ventricular dysfunction without any reason. You may have some mild degrees of unexplained pulmonary hypertension. You may have a MR, which is very mild, but when you put the Doppler, you'll get a gradient of 180 millimeters of mercury from LA, and you won't be knowing what is the reason, why the LVSP is so high. The mild flow gradients across the mitral and the aortic valve, the mitral valve gradient may be 1.62 meter per second, or the aortic valve gradient may be 1 or 2 meter per second, slightly higher than normal. And especially if the patient is also having a bicuspid aortic valve, think about a coarctation. The second channel is a proper three-dimensional imaging. Echo alone is feasible to diagnose a coarctation only in neonates and young infants. The majority of the older patients will need some form of three-dimensional imaging, either in the form of CT or MR, or sometimes even a conventional angiography. There are newer modes of imaging which even look at what is the vessel wall, compliance vessel wall, architecture, the elasticity of the vessel wall, the expansibility of the vessel wall, and these are done by advanced DMR technologies. Now coming to indication, let's talk about indications for a coarctation. Stenting. So straight away I'm starting with stenting, not talking about balloon dilatation. Why? Stenting tackles the dissections that happen after balloon dilatation. Balloon dilatation may recoil, but stent will prevent the recoil. Stent balloon dilatation indiscriminately can produce an aneurysm, whereas the stenting will produce a controlled tear and a controlled tacking of the dissection that aneurysms are avoided. And most important, it completely eliminates the gradient. There won't be, you will come out of the lab with a zero gradient if you are doing a coarctation stent. But then the question, why not stent all the coarctations? Aorta grows till 14 to 18 years of age. And so if you are stenting the coarctation, a patient who is less than 14 to 18 years, we need to remember that the patient will need a redilatation. That means you have to put in a stent that is redilatable. Vascular complications are very high in the CCISC registry from the United States of America. If the weight is less than 25 kilogram and the age is less than 8 kilogram, and so this parameter has to be respected. In discrete coarctation with very good sized isthmus, we may get excellent result with ballooning alone, and hence there may be a role for a balloon dilatation. This is an example for a very discrete coarctation with a good-sized isthmus, good-sized transverse arch. And in these patients, many operators will consider only a balloon. So this is an example of a very discrete coarctation. And so what you do in these patients is match the size of the balloon to the size of the isthmus. And unlike balloon aortic valvotomy, where you rapidly deflate the balloon, here keep the balloon inflated for about 20 seconds or 30 seconds in order to tack the intimal tear and tack the dissections. Keep the intima pressed against the media and adventitia, and you will come out with a good result, but with a therapeutic tear. I'm calling it as a therapeutic tear because if you don't create a small intimal dissection, that vessel is not going to enlarge. So you need to have what is called as a small therapeutic tear. And this becomes the major concern of this procedure. In majority of the normal aorta with a normal aortic architecture, this small therapeutic tear seals up on its own. However, in a patient who is genetically predisposed, like for example, a Turner syndrome, or a patient who is having a form of an aortopathy, as in the cases of bicuspid aortic valve with aneurysmal ascending or descending thoracic aorta, they may have an associated cystic medial necrosis, which will allow these therapeutic small intimal tears to spread through the media and create a whole dissections. And this is one of the concern of this procedure. And that is the reason why in a grown-up patient with a dilated descending post-coarctation aorta, we tend to avoid a simple balloon dilatation. The bottleneck of this procedure is therapeutic tear and the intimal dissection. When you see on the post-operative echocardiography, you will find that there is an intimal tear that is plopping here. And if this patient turns out to be having some form of aortopathy, there may be a progression of this tear. Otherwise, majority of the tears will heal on its own. So, what is the anatomical indication for a stenting? If you are having not a discrete coarctation, but an associated isthmic hypoplasia, what is isthmus? Isthmus is the portion between the region of coarctation and this left subclavian artery. So in this region also, if it is smaller, that means this patient is not going to get a good result with balloon dilatation alone, or if the patient is having an associated PD. So if we have to summarize the reasons for elective stenting, isthmic hypoplasia or transverse aortic hypoplasia, if there is an associated PDA and any adolescent or any adult and in extremely tight coarctation or near interruption, we need to be going with actually a covered stent. So this is a coarctation with a patent ductus arteriosus. You can deal with it in two ways. One is use a covered stent, that is more expensive way of dealing with the situation, or put in a PDA device and then put in a bare metal stent and address both the PDA device closure plus the coarctation in one go. About the imaging, if you don't have a prior CT image or a prior MR image, then one of the things that you can do in your own cath lab is what is called as a rotational angiography, which is within the reach of the interventionist. He can plan the stenting on the same day of the procedure. We will think that there will be a dose of additional contrast, but truly it's not so, because we are going to be diluting the contrast here, and the 3D overlay may be feasible in some of the labs. So this is a rotational angiography of a long segment coarctation that is being done. The moment you do this rotational angiography with a 2:1 dilution contrast, you can reconstruct and create a 3D image and make some measurements. You can plan the angle at which you want to do it. For example, in this particular patient, I would rather fix at this image. This may be the best image for me. So I will go and find out what is the LAO cranial projection that I need to get for this, and then deploy the stent, and following the stent again see in all the circumferential areas. And this is one of the advantages of a rotational angiography. The rotational angiography especially helps if you are very, very close to one of the arch vessels, very commonly the subclavian artery. Here you see that the subclavian artery is arising bang at the level of the coarctation. And in these patients, when you do the coarctation, you'll be able to, you can now see that the coarctation stent has been placed. The stent is 50% protruding into the region of the left subclavian artery. I will show it in this spray. So this is the left subclavian artery. The stent is protruding. This is done by 2:1 contrast dilution with 180 degrees spin, 40 degrees of rotation per second. So this means it's a 4.5 second rotation. You inject at a rate of 15 to 18 ml per second. Sometimes you can use a rapid pacing to reduce the cardiac output in order to get a very good picture. And the patient, if he holds the breath, it will give excellent images, and you will be able to do good reconstruction. The standard procedure that we follow will be to use a marker pigtail, because if you calibrate with the catheter, which is just 1.7 millimeter or 2 millimeter, if it is a 5 French or 6 French catheter, there will be like errors. Whereas if you are having a marker pigtail with a 1 centimeter marker and you calibrate with a 1 centimeter or a 2 centimeter marker, it's going to be far more accurate. If there is no prior imaging at all in the CT scan and you want to do the first angiogram, either a LAO view with a 20-degree caudal projection, or this is actually an LAO 40 with a 30 caudal. The reason why I'm saying caudal is that whenever there is a fold of the proximal coarctation area, that fold will go off with a caudal projection. So LAO caudal or a lateral caudal will be the first projection to plan the first angiography. The techniques to ensure that the safety of the procedure is maintained: choose a balloon diameter that is equal to the proximal distance. park the guide wire tip, if possible, in the right subclavian artery rather than the ascending aorta, because if there is a bicuspid aortic valve with a weakened ascending aorta and a cystic medial necrosis in the ascending aorta, a dangling stiff wire in the ascending aorta may harm the area more. Take the balloon stent assembly always within a long sheath. Avoid stent slippage by minimal inflation of the balloon. After you do the balloon dilatation, crimping of the stent over the balloon, if you have given a negative on the inflation device, release the negative. Maybe inject about 0.2 to 0.3 ml of contrast in order to fill the balloon on either side of the stent. Use a 3 French larger sheath if you are using a covered stent. Always use an inflation device to slowly deploy the stent and never hand inflate. Use somebody else to use the inflation device, and as he is expanding, be prepared to hold the balloon and move a little up or a little down depending on what is the movement of the balloon and stent during the procedure. If you feel that the coarctation is not extremely tight or something like a near interruption, be prepared for a rapid RV pacing in order to reduce the cardiac output. Keep the sheath tip just distal to the balloon and not pull it too much into the abdominal aorta. This will prevent the downward migration of the balloon and the stent assembly. Some special situations, like for example, a near interruption. This is a patient who is having a complete near interruption. You inject from the top and you hardly see any contrast filling down. And when you inject from the bottom, you are able to see that you are having a large area of descending thoracic aorta, and this area is totally interrupted. So in these patients, you cross from the top with a straight termo wire and snare it from the bottom. And once you have snared, insert a 5 French pigtail and make an angiography. You will see that the 5 French pigtail is actually a snug fit. It is not allowing the contrast to spill into the descending thoracic aorta. That means the size of this coarctation is hardly 1.7 millimeters. And if you have to directly go for a stenting, the rule is that more than 3 to 3.5 millimeters, the coarctation diameter, if you go in, the patient is likely to have an aortic rupture. So, but we know that this may be a soft lesion. So what we do in these patients will be insert a very soft balloon, like a Ty-Shak balloon, and inflate it with half atmosphere or maybe 3/4 of an atmosphere. Some of these so-called near interruptions may be actually a very soft vessel inside, and it may become a little roomy. At the end of it, then you repeat an angiogram. Now you find that the same coarctation is now looking around 3.5 millimeters. So this 3.5 millimeter now is probably easily amenable for a stent of around 10 to 12 millimeters. So after doing the re-angiogram, this coarctation now with a marker pigtail, we are calibrating, and it's almost measuring 4.5 millimeters. So you now put in a covered CP stent, which is 39 millimeter over a 16 millimeter bib balloon, and you inflate. Bare stents are not very safe in this situation, and we can use a covered stent. If covered CP stent is not available, the other covered stents that are available currently in the market are covered Andra stent, covered Optimus CVS stent, which is available from the company called Andra Tech, and covered B-Graft, which is also another German company. All the three are cobalt chromium stents, whereas CP stent is a platinum iridium stent. This is the final angiography. Now coming to another situation where stent can malposition, stent can migrate, or there can be balloon melancy. This is a post-subclavian coarctation in a 5-year-old child who had a subclavian flap aortoplasty in early infancy. You can appreciate that only the vertebral artery is going there, and only the carotid artery is going there, and the subclavian is spilling from the vertebral artery. So in these patients, we go for a stent. And now when we are inflating the stent, remember this is a post-subclavian, the post-surgical lesion, which will be very, very rigid. Now you keep watching as the balloon is getting inflated. The balloon inflates, but the balloon melancetes down. This is what I was telling, that we should have the sheath tip very close to the balloon. If we don't keep it, the balloon sort of melancetes down. And now when it is melanceting, the stent tries to get displaced proximally. Now it is more into the aortic arch. So when such a situation, this is because it's a longer balloon in a curved arch segment. The balloon had a longer taper, and we did not. So now what we have done is we have taken a smaller profile balloon, passed through the coarctation, inflated it, and when the balloon is getting inflated, just pulled the balloon and the stent assembly back into the region of the coarctation. And once that is done, then the stent is further expanded. And this is the final result wherein we have got the stent deployed. So remember, balloon melon seeding or the stent migration may be related to usage of longer balloons, longer taper balloons, or not having the sheath at the bottom. So these are all some of the issues. Of course, you can prevent it to some extent by a rapid RV pacing also. This is a classical example of a patient who is having a tight coarctation, which after positioning the stent, a rapid pacing wire is introduced, and on pacing, now we are inflating the stent. And this ensures that the stent doesn't move at all. You can see that there is no much of movement of the stent, and this ensures that the procedure is reasonably safe. So ways to avoid a stent malposition will be to use what is called as a bib balloon, a balloon in balloon, or a rapid RV pacing. Avoid long taper balloons, avoid balloons that are longer than the stent, and if possible, use pre-mounted stents. Previously, at Atrium V12 was available, but now the B graft is available, which is a pre-mounted stent, or the pre-mounted CP stents are available. They can also be used. Balloon rupture is another messy complication. If that happens, then we have to deal with it. This is a patient, again, a post-surgical coarctation with a clip that is placed on the ductus by the surgeon. So this actually produces an altered compliance. The anterior part of the aorta is a rigid metal. The posterior part of the aorta is a soft vessel. And when the balloon is getting inflated, this sharp metal clip that is present on the anterior wall of the aorta now ruptures this balloon. You can see that the contrast is now spilling out. So the stent can no longer be dilated properly. So in these cases, you may have to introduce another very low profile balloon to cross the lesion and then ensure that it is expanded fully. So we should be able to have a lot of low profile balloons which can go to high pressure. One of the balloon that is currently available, which is available from the Boston Scientific, is Mustang balloon, which is a balloon that is very low in its profile, and it can retrieve these situations when the initial balloon ruptures. So this is after deploying the stent, after expanding, how we get. So the way to understand which vessel will not be compliant at all, in such cases, sometimes a softer Ty-Shak balloon inflation to a 0.5 to 1 atmospheres may help in studying the vessel wall compliance. And this can tell us whether the stent balloon is going to get ruptured or not. Transverse arch stent is another very complex region. When a transverse arch stent is across the region between the left carotid and left subclavian artery, we need to plan it out properly. And always we have to use one of the bare stents. So this is a bare stent that is being placed. And as we are expanding, again, you see that this is a patient who is having a long tapered balloon. Despite keeping the sheath here, the balloon tends to melon seed and it tries to come out because the curvature of the aorta is not being taken by the curvature of the curvature of the arch is not being taken by the curvature. So once again, the strategy is passing in a smaller balloon, which is low profile, and then getting it and inflating the proximal portion. So now this is a total expansion of the stent across the transverse arch, of course, jailing the left subclavian artery because the lesion was between the left carotid and the left subclavian artery. So jailing the left subclavian artery was possibly mandated. So this is the follow-up CT scan of the patient, which is having a preserved carotid flow. Left subclavian was even previously a bit stenosed, and so you still have flows. So the messages out of coarctation is in tight coarctation, almost amounting to near interruption. You snare the guide wire from the top, and you pass the guide wire from the top and snare it from the bottom. That means you have to get a radial axis and a femoral axis. Use low pressure Ty-Shak balloons to create a lumen in case of extremely narrow coarctation. Same thing, also use it to check the compliance in a post-surgical coarctation if there are metallic clips around the region of coarctation. Avoid long taper balloons in the aortic arch. The stent length preferably should always match the balloon length, at least in the arch stenting. High pressure balloons in postoperative non-compliant coarctation may be needed, which are like, for example, a Mustang balloon that I mentioned, or sometimes rarely even an Atlas balloon. Rapid RV pacing will prevent a migration in mild coarctations. Keep always covered stents in your shell. Keep always low profile, high pressure balloons in your shell. For any stent migration, you may have to go and pass a balloon through that partially deployed stent and get it fixed in a proper position. Radial access arm catheter will help in guiding the position of the arch stent. Now, this is completely now jumping into a diverse, another topic, PFO closure. I have been told only to talk about the technical aspects. But before knowing the technical aspects, we should know why we should do a PFO closure. In a patient who is having a proven paradoxical embolism or clear MRI documented embolic strokes, it's justified. In rare patients who have significant platypnea orthodeoxia, the patient on a standing position is perfectly fine, but when he lies down, he says that he's a little bit breathless and his saturation drops down to 85 to 90. Or occasionally, rarely, in something like diverse illness. Now, I need to tell you one more thing. There may be some patients who do not have any of these things, but we will do it. One is, if you do a transesophageal echocardiography for some other reason, a patient who is presenting with some breathlessness, with features suggestive of maybe pulmonary embolism, and you see that there is a thrombus in transit. Now watch this patient. This is a patient who presented with mild pulmonary embolism with breathlessness, who otherwise will qualify for only a thrombolytic therapy followed by oral anticoagulation, preserved right ventricular contractility, but you have a thrombus. This is a cardiac MRI, which is migrating, which is straddling across the patent foramen ovale. Of course, MRI spatial resolution is very less. See it on transesophageal echocardiography. A thrombus is actually in the process of migration. Now, this patient, the moment we gave, in fact, it was this patient actually, this was done after the initial thrombolysis that was done. And then MRI showed this picture, and then the transesophageal echocardiograph showed it. So this patient is not immediately suitable for a open heart surgery because the patient had just been thrombolized. And fortunately, because of the thrombolysis, the entire thrombus sort of fortunately lysed properly without causing any embolic event. And in this patient, we know that there is a potential thrombus in transit. And so after the effect of the thrombolysis goes off, if there is no residual thrombus in transit and the patient is relatively stable, you may have to go and close this PFO, even in the absence of a previous paradoxical embolism. What helps us to identify a right-left shunt in a patient is agitated saline echocardiography, which is the gold standard in diagnosis. We also, neurologists or the radiologists who do a transcranial ultrasound will look at high intensity signals in the middle cerebral artery. But more reliable for a cardiologist is either a thoracic echocardiography or a transesophageal echocardiography, where you fill the right atrium with contrast and you see that instantaneously there is a filling of the left atrium. Whenever there is a PFO with an atrial septal aneurysm, there is an incidence of stroke tremendously improves. This is a huge atrial septal aneurysm with a septal length of more than 15 millimeters, which is a very high risk for paradoxical embolism. And in these patients, when you do a contrast echocardiography, you will find that there are plenty of showers of right to left shunt, and a PFO with atrial septal aneurysm carries a risk of around 5-fold higher paradoxical embolism than a regular PFO. So if there is a PFO with a large atrial septal aneurysm more than 15 millimeters, consider this also as an indication for closure. Now, some of the technical aspects of a PFO closure, there will be some PFOs which are typically like a tunnel. This is a transesophageal echocardiography. We are actually viewing a telescopic view of the tunnel. You can see that only when I get onto the plane of the atrial septum, I'm able to visualize the tunnel, and I will freeze the image now when I am seeing on the plane. So I'm actually seeing along the plane, and now I get the tunnel. And if I tilt it to the left atrial view, I don't see the PFO at all. So in these patients, it's very important to do a balloon evaluation, because the balloon is going to tell us whether this tunnel will need a transeptal puncture and a different entry, or whether it can be entered through itself. Here you find that the balloon waist is rather discrete, and in these patients, you can just go ahead and close the PFO like any PFOs. So this is an example of an 18 by 25 PFO device. So 18 millimeter on the left atrial side, 25 millimeter on the right atrial side. You do a conventional regular wiggling, and after the wiggle, then you release the device and come out. So this is a typical normal wiggle test, and then you come out. This is the size matrix of the PFO devices. It can be 18-18 or 18-25 or 25-35. In the two sizes, PFO 25 and PFO 35, the right atrial disc is larger than the left atrial disc. So whenever there is a long tunnel, what we try to do will be an intracardiac echocardiography. This is an intracardiac echocardiography. We cross the PFO with the guide wire, and we see that if the tunnel is quite long, the tunnel is going to be quite like very, very, very long, then we resort to a transeptal puncture. So this is a transeptal puncture that is being done, and you do a transeptal puncture away from the region of the tunnel. So go through a normal portion of the septum, but reasonably close to the tunnel, and then deploy the device. So this is the left atrial disc that is coming up, and then the right atrial disc, and the procedure is completed. The post-procedural protocol that we follow is aspirin and clopidogrel for 1 year. We do a follow-up transesophageal echocardiography with agitated saline at the end of 1 year and confirm that there is no right to left shunt. And when there is no shower of agitated saline on the left atrium at the end of 1 year, we discontinue the drugs. To summarize, PFO is clearly indicated in all patients with patent foramen ovale associated with paradoxical embolism and documented cardioembolic strokes on the MRI. Right to left shunt should be documented on an agitated saline injection. We should have a low threshold in atrial septal aneurysm. I would also say that low threshold in a patient who has a past history of thrombus in transit. Septal puncture is ideal for all the tunnel PFOs. Thank you very much for your kind attention. I don't know whether I exceeded the time. I once again thank the organizers, the president, Dr. Duminda, Dr. Shehan Pereira. Duminda and Shehan had been extremely nice, close friends, and all the other senior colleagues of Sri Lanka Heart Association, Sri Lanka College of Cardiology. It's indeed a pleasure for me. Unfortunately, I was not able to come because parallelly I am sitting in the Pediatric Cardiac Society of India annual conference that is happening in India, in Kolkata. And it was difficult for me to plan the travel to two diverse centers. I thank you all for your kind invitation to me.
Thank you, Dr. Sivakumar, for that excellent and informative lecture. We always appreciate your lectures because you reason out each and every step very well. And hopefully we'll see you next year in our meeting. Thank you again. We'll show our appreciation in our usual way.
So our next speaker is Professor Ziad Hijazi. He's a professor of medicine and pediatrics. He's working in Weill Cornell Medicine, New York. He's an interventional cardiologist specializing in congenital and structural heart disease in both in children and adult. Professor Hijazi has over 360 peer-reviewed publications, 9 books under his name, and over 60 chapters of hundreds of abstracts. And he's the first person to describe ICE, intracardiac echocardiography, using guided PFO and AC closure, as well as he's the first person to use Amplastar device AC closure in US, and he's the first person to implant pulmonary valve in 2013 in US. Without further ado, I will invite Professor Hijazi to talk on pulmonary fistula closure and coronary fistula closure. Over to you, sir.
Thank you so much. Good morning, everyone. I'd like first to start by thanking the organizers for inviting me. It's indeed my pleasure and the privilege and honor to be invited to be with you in the Sri Lankan College of Cardiology. Do you mind if they play my presentation? Because I did not prepare the laptop. They said they'll play my presentation. Is that okay? Greetings from Doha, the host city of the World Cup 2022, which will be just about less than 3 weeks from today. This is Ziad Hijazi from Sidron Medicine. First, my deepest apologies for not being able to be with you in person, but this is the next best thing. Today, my talk is about transcatheter occlusion of coronary arteriovenous fistulas as well as pulmonary AV malformations. This is my disclosure slide, which is non-related to this talk. We're going to start with transcatheter closure of coronary arteriovenous connections. Coronary arteriovenous connections are communications between the coronary arteries and the cardiac chambers. The other name is coronary cameral fistulae, or the other vessels, coronary arteriovenous malformations. Just to let you know that we have written a recent article about congenital aortocardiac connections. And in this article, we have revisited the naming of these fistulae or connections. And based on the type of connections, we devised a treatment strategy. I advise all of you to download this article and read it so that you can understand this concept very well. In that paper, we divided the congenital arteriocardiac connections into the type of connector, whether it's a hole or a channel. If it's a channel, anatomic type 2, or extra anatomic type 3. If it's extra anatomic, it's either intramural or extramural. And you will see in this the type of connection is that type 3A and type 3B. The etiology of these connections most of the time is congenital, but on rare occasion it is acquired after a trauma, a stab wound or a gunshot or a projectile injury. The incidence of coronary arteriovenous connections is about 0.3% of all forms of congenital heart disease. In adults who undergo coronary angiography, the incidence between 0.13 to 0.22% of all patients undergoing coronary angiography. Most of them, of course, are asymptomatic. Based on the origin of the connection from what artery, majority are from the right coronary artery, 55%, the remainder 35% from the left, and of course the rest of the percentage is combined origin. The drainage site, majority of them into the right ventricle at 40%, 26% into the right atrium, 17% into the pulmonary artery, and the remaining percentage is multiple drainage sites. The sequelae of these connections, they may lead to ischemia and angina. If they are large, they may lead to heart failure and cardiomyopathy, sometimes myocardial infarction. They may lead to pulmonary hypertension, end arteritis, rhythm disturbance, thrombosis, and rarely rupture of these fistulae. Management decision in these patients, it depends on the size of the fistula, presence of symptoms and complications, the age of the patient, the anatomy of the fistula, and presence of other indications to undergo invasive procedures. we've written a paper in Circulation about recommendation for coronary arteriovenous fistula, as you can see, divided into class 1, class 2A, and the class 3. Class 1, if there is a continuous murmur, the origin should be defined either by echo, MRI, CT angiography, or cardiac catheterization. If you have a large fistula, regardless of symptomatology, this should be closed via either transcatheter or surgical route, or if you have a small to moderate fistula in the presence of documented myocardial ischemia, arrhythmia, and otherwise unexplained ventricular systolic or diastolic dysfunction or enlargement or end arteritis, these should be closed via either a transcatheter or surgical approach. In class 2A, if clinical follow-up is indicated with echo every 3 to 5 years, can be useful in patients with a small asymptomatic fistula. Class 3, which means you should not do anything if patients with a small asymptomatic coronary fistula. This diagram gives you a flow chart what to do with coronary artery fistula. On the left-hand side, if they are proximal fistulae and it's medium to large, plus minus symptoms, the patient should undergo closure, either transcatheter or surgical closure, plus anticoagulation. If they are small with no symptoms, obviously you may need just to do observation of these patients. You may give them anticoagulation. In these cases, they do not need anticoagulation or antiplatelets. If it's distal fistula, again, you look at the size. If it's a small, just observation and no need for anticoagulation. If they are medium to large, with or without symptoms, obviously you need to do intervention, either transcatheter or surgical closure, plus anticoagulation or antiplatelet therapy. So depending on the size of the fistula, you look at the relative size. You may measure the QP to QS, QP-QS ratio, but I want you to be aware that the amount of blood that supplies the entire heart, which is the coronary flow, is about 5% from the entire cardiac output. So QP-QS in the majority of patients will not be large, except if the fistula is really huge, similar to the case that I will share with you later. Also, you look at the aneurysmal dilatation or tortuosity of the fistula. Based on the symptoms, if they have heart failure, like one neonate presented to us with severe heart failure, but in 50% of symptomatic neonates, they may become asymptomatic with size of fistula decreasing over time. There is a spontaneous closure has been seen in some patients. Also, angina, arrhythmia, shortness of breath may be seen in adults, and endocarditis is rare at 3% of the patients. Age of the patient, again, as I mentioned, spontaneous regression in some patients with advancing age. Size and developmental maturity of patients is important. Elective closure in children with medium to large fistula is reasonable. As I mentioned by the indications, it's class 2A. Presence of other congenital heart disease, indications for surgery or transcatheter in some patients with tetralogy fallot, PDA, ASD, pulmonary atresia. This is present in 10 to 30% of the patients. Surgery for closure of these fistula has been first performed in 1958. External closure versus intracardiac closure, mortality is very low, but there is recurrence or incomplete closure in about 10%. Catheter intervention goes back to 1983, very low mortality. At that time, Many devices have been used, from detachable balloons, Gianturco coils, Rashkind umbrella, Amplatzer devices, and most recently we have been using Amplatzer vascular plugs, as well as covered stents if there is multiple exit sites for these fistulas. Closure in the cath lab is applicable for more than 90% of the patients. There is a chance of a small residual or recurrence of the fistula in about 10% of the patients. Technique of closure: either you can go retrograde with coaxial technique using coils or vascular plugs, or we close it anterograde. In these patients, you will need to create an arteriovenous loop. Let's discuss the retrograde approach. This is a case of a 48-year female patient with large circumflex to coronary sinus fistula. She presented with shortness of breath and fatigue. We closed her fistula successfully using 6 coils, 2 Nestor coils and 4 Gianturco coils, and she was discharged home the following day on no medications at all. And I am emphasizing here on no medications because you will see now what happened to this lady. So this is the angiogram. You can see the circumflex to the coronary sinus drainage, and this is the angiogram after 6 coils. The circumflex is patent, and the other branches are patent as well. 4 days later, she presented to the emergency department with chest pain. Therefore, she was diagnosed to have myocardial infarction. Repeat angiogram, complete occlusion of the left circumflex coronary artery. Look at this angio, there are the coils, and of course no circumflex because it was occluded completely by propagation of the clot proximally. This is a very serious issue, and that's why these patients need to be placed on either anticoagulation or antiplatelets. This is a child 4 years of age with LAD to RV fistula. So we did retrograde with a 4 French catheter. Then we put a tracker catheter inside the 4 French catheter or a micro catheter. We put a balloon tipped catheter there with occlusion to delineate the exit as well as the myocardial viable branches. The first coil was detachable coil, 8 mm by 20 cm. There is the angios. Then second coil, similar size, 8 mm by 20 cm. Then we kept putting coils in this patient until we occluded the fistula completely. The videos are playing for you, showing you the deployment of all these third and fourth coils, 4 mm by 8 cm. You can see angio, there's still some flow. Then the fifth coil was 6 mm by 20 cm. The goal usually is to achieve complete closure in the cath lab. On occasion, when there is trivial residual leak, we don't go after it because we're confident that this will close with time. And you can see here complete occlusion. Obviously, you can see the slow flow in the LAD. So this patient, it is extremely important to put her on Coumadin and bridge her to warfarin for 6 months until the fistula completely closed and there is good flow, and then we bridged her to antiplatelet for the remainder of her life. The anterograde approach, you will need to establish arteriovenous loop, and this is an example in this case. 2-week young female neonate with very large fistula. She weighs 2.3 kilograms, but she was presented to us with severe heart failure. And we performed cardiac catheterization from the left femoral artery, 4 French, left femoral vein, 4 French, and the right internal jugular, 7 French. So Obviously, she had systemic PA pressure. The QPQS was infinite. We used the first device, a 12 millimeter ambulatory muscular VSD device and 7 flipper coils. There was still significant residual shunt. We brought here for second cath. We get access from the left femoral vein for French, left femoral artery for French, right carotid cut down 8 French. We reassessed the pressure, still elevated but better than before, and the QPQS was definitely better but still massive, and we put additional devices, 10-8 duct occlude, as well as 8 millimeter Gianturco Grifka vascular occlusion device. By the way, this device now ceased to exist because the manufacturer stopped manufacturing it. Repeat QPQS after all of this came down to 3-1, and this patient now is alive after 15 years from this cardiac catheterization. This is the first angio. Look at the size of this fistula, massive fistula. So we crossed and snared from the IJ. You can see the snaring from the IJ. And then we put a large sheath from the right IJ, 7 French. And then we deployed the ambulatory muscular VSD device at 12 millimeter, as distal as possible. And then after we released this device, on top of it, we deployed 7 coils. But after that, and because we gave a large amount of contrast, we stopped and we brought her back after a couple of days, and we closed the remaining fistula with other devices. I'll let this play so that you can see there's the coils. That's the end of the cardiac cath. Then the second cath, as you can see, I'm putting now the PDA device from the right carotid artery. Then on top of it, I put a Gianturco Grifka vascular occlusion device. There is the Gianturco Grifka vascular occlusion device. And then the patient did very well. And the final angio, you can see the remainder of the coronary arteries, they fill very well. And as I mentioned, this child is over 15 years of age now, doing extremely well, and she continues to receive a baby aspirin for the rest of her life. Long-term outcome, the majority of these patients, they do well. Small residual leaks in about 10%, persistent dilation of the coronary artery, late stenosis, arrhythmias, acute or late occlusion with or without myocardial infarction. Follow-up is mandatory, and appropriate tests should be done for these patients to look at the coronary arteries. Now let's shift to pulmonary arteriovenous malformations. These are direct connections between the pulmonary artery and the pulmonary vein. So we bypass the capillary bed, therefore no oxygenation. So this results in right to left shunt. When you have right to left shunt, this may lead to hypoxemia if it's large, dyspnea, paradoxical emboli that may lead to stroke, cerebral abscess, myocardial infarction, or sometimes you may have pulmonary hemorrhage due to rupture. This condition is associated with hereditary hemorrhagic telangiectasia in 47 to 80% of the cases. Endovascular occlusion is the preferred management for these patients. Nowadays, rarely we perform surgery, but if they are diffuse, you may need to do lobectomy or entire pneumectomy. Etiology. Again, congenital in the majority of the patients, and as I mentioned, 80 to 90% are associated with hereditary hemorrhagic telangiectasia, which is Osler-Weber-Rendau disease. They could be acquired, especially in patients after chest trauma, after the Glenn shunt, the Kawashima procedure, hepatopulmonary syndrome, or congenital portosystemic shunts. The European guidelines in 2019 for management, if the feeding artery is 2 millimeter or larger, they intervene. If they are increasing in size, they intervene. If the patient had a paradoxical embolism, they intervene. If the patient develops symptoms of dyspnea, they also intervene. This is a patient who had a couple of fistulae, pulmonary arteriovenous malformations. We access the femoral artery. We deploy a sheath as distal as possible, repeat the angios, then deploy devices as distal as possible to eliminate the right to left shunt. You can see here we put Amplatzer devices and Amplatzer plugs to eliminate the right to left shunt. This patient improved, but when this patient presented to us, she presented because of paradoxical embolism. This is a flow diagram showing that if symptomatic patients like epistaxis, dyspnea, hemoptysis, TIAs, stroke, or they could be asymptomatic, incidental finding, or if they have hereditary hemorrhagic telangiectasia, you screen them with chest X-ray, sometimes with oxygen saturation, with arterial oxygen content, and you may also, if these tests are all positive, you may do a chest CT. If they are negative, you stop there. If the chest CT is positive, you look for pulmonary AVMs. If they are large, you may need to do something. If they are small, you may just follow these patients up. So it's extremely important that you do your workup completely for these patients upon presentations. So in conclusion, coronary arteriovenous connections are not uncommon. Knowledge of indications when to close is important. Knowledge of the size, site of drainage, and available devices should help in managing these patients. Working with our colleagues in adult cardiology for these coronary fistulas is extremely important because they know about coronaries more than the pediatric cardiologist. So it's important to work with them. Also, for adult patients, it's important to put them in the adult CCU so that if any EKG changes, enzyme changes, or symptoms, intervention can be activated immediately. Also, these patients, they require anticoagulation or antiplatelets. Pulmonary AVMs, the same thing. We would like to work with our colleagues in interventional radiology because they have materials that may not be readily available in the pediatric cath lab. Again, knowledge as to when to intervene is extremely important. Thank you for your attention, and I hope that you will join us in the PICS Symposium, which will be held in Istanbul in March of next year. Thank you again.
Thank you very much, Professor Hijazi, for that excellent
Took a bit longer than the indicated time. My apologies.
Thank you very much.
Thank you.
That's the end of our session, pre-lunch session. I think we can break for lunch now.
And all the chairpersons, I'd just like to make a few announcements. We have a small change in our schedule. One thing is Dr. Pradeep Kumar is coming especially from the Maldives to give a lecture on guidewires, and he's on his way here. And also we have Professor Goran Stankovic, who is coming on at 1:30 as scheduled for his master class on bifurcations. So we need all of you all to break for lunch and be back here the latest by 12:55. This gives you all 30 minutes for lunch.